So, just to give you a little bit of background on the atlanto-occipital or OA joint, it is a synovial joint of the upper cervical spine. In fact, it is the highest level joint in the entire neck. And it has two articulating surfaces on each side that you can see over here in green. On the top, you have the occipital condyles of the skull, and they articulate with this beneath it, and this is the superior articular facet of the atlas or the C1 vertebra. Now, there are several motions allowed by the OA joint. One is motion in the sagittal plane. So the OA joint by itself allows 10 degrees of flexion and 20 degrees of extension. Now, obviously, in the entire neck, we have much more flexion, much more extension. The remainder of those movements is provided by the segments of the lower cervical spine. Okay, but 10 degrees of flexion, 20 degrees of extension. In the coronal plane or frontal plane, it allows 8 to 10 degrees of side bending in each direction. Once again, the remainder of that movement is provided by the segments of the lower cervical spine. And there is a little bit of rotation that occurs here. It's only about 5 to 7 degrees, and it occurs with that side bending. So when I side bend this way, there's also some rotation that occurs due to the slanted nature of each of those facets, okay? But we usually don't consider rotation at all. In fact, the main ones we consider are this flexion and extension. Now, like any joint, it can have restrictions in movement. The most common OA joint restriction is flexion. So remember that we've got two main movements of the upper cervical spine. We have upper cervical flexion, which involves cervical retraction, and then we've got upper cervical extension, which involves cervical protraction. And you can see those two things down here. So why is the most common OA restriction flexion? Well, it's because we're more often postured in this society in OA extension or upper cervical extension like this. We're typing on computers, doing homework, watching TV, etc. And less often we're postured like this. So generally speaking, there's not usually going to be limitations in OA extension. It's going to be OA flexion. But you can never assume those things. You need to test it, and that's what we're going to go over on the next slide. Let's take a look.
So as we continue here, please ignore the obvious continuity errors throughout the video that you might see. But we need to test the mobility of the OA joint, the atlanto-occipital joint. The atlanto-occipital joint has two movements on each side. It facilitates flexion and extension. Those are the main two that we care about. Note that you are going to see significantly more restrictions in flexion than you will extension. I have never seen an extension limitation. It's pretty much always going to be flexion, and even for people much more experienced than me, they will also say this because we often sit like this at a computer screen. So we definitely have that upper cervical extension. It's the flexion that's going to be limited. So to perform this assessment, the patient will be positioned in supine, like you see right here. The PT is going to use one hand, we'll call it hand one, under the occiput to position the patient's head in upper cervical flexion. So basically a gentle chin tuck or gentle cervical retraction, okay? And then the PT will place their other hand on the patient's forehead. That's going to be hand two while stabilizing the occiput with hand one. So let's see that position right here. So my stabilizing hand is going to be my left one. I've got it under her occiput. And then I'm going to put my other hand, hand two, on her forehead, okay? So this is the test position. From here, the PT is going to rotate the patient's head approximately 20 degrees toward the side being tested while maintaining that gentle chin tuck or gentle cervical retraction, okay? So here's 20 degrees to the right, and then while stabilizing with hand one, the PT applies a firm pressure into cervical retraction, monitors for end feel and any subjective reports from the patient. So here I'm doing that mobility testing. Again, I'm not losing that cervical retraction. Be sure that you keep that. Once you've felt that, rotate to the other side. You should switch hands as I've done right here, and then same thing. Now, in this case, she doesn't have any restriction here. But understand that clinically, when you have a restriction in this, it can be from multiple sources. It could be from the joint itself, but it can also be if the muscles around the neck are extremely tight. If the muscles are very, very tight, doing any testing or especially mobilizations on this is going to be pretty much impossible. You're going to have to loosen up those muscles first before you attempt to mobilize this. And this is true with muscles that are extremely tight. Okay, so that's assessment for OA flexion. And again, you will probably never or very rarely ever see a limitation in atlanto-occipital extension, but just in case you wanted to test it, here's how you do it. The patient will be positioned in supine, just like you see here, and the hand placement is going to be exactly the same. We're going to rotate the patient's head one direction. That's the side we're testing. So in this case, we're testing the right atlanto-occipital joint. But this time we're moving the patient's head into upper cervical extension, or generally cervical protraction. Okay, so here we go. So there's that cervical protraction. Once we're confident with that result, we then rotate the head 20 degrees the other direction and repeat the same process. Now, before we go any further here and talk about actual mobilizations, a really important note to hit that I think is glossed over in a lot of courses, and it's such an easy thing, but for some reason it's not well elucidated, and it's what side you're actually testing, okay? So the rule is here, you're always testing the ipsilateral side, ipsilateral to the direction of rotation. So when I get her in this position, this would be for OA flexion as you see here, when I rotate her head to the right, as you see right there, that is testing the right OA joint. I don't care if it's flexion or if I'm doing the extension one from a minute ago. It is always ipsilateral testing, okay? So what I'm doing here is testing right OA flexion, okay? When I then rotate her head to the left, this would be testing left OA flexion. So big important thing here is if you have a restriction with 20 degrees of rotation to the left, that is a restriction of the left OA joint, and that is the side that you mobilize. So it's always ipsilateral testing. So that then leads us to the treatment, the mobilizations. And for the sake of this video, we're only going to focus on the OA flexion restrictions, just because, as I've mentioned, extension you're probably never going to run into clinically. And if you do it the exact same way, it's just everything's in the opposite direction. It's going to be protraction rather than retraction, okay? So OA flexion restriction. Option one is to do what's called an OA distraction manipulation. You can see it pictured right here. Generally, you're going to bias either 20 degrees of rotation to the right or left to hit one of the OA joints, whichever is stiff. The thing here is that it's not necessary. And we could also talk about the risks associated here, okay? There are risks associated with manipulations, especially when you're dealing with the upper cervical spine, and I'm thinking cervical arterial dysfunction. Again, that risk is very, 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 very low, especially if you're doing appropriate screening, but you can't ever completely negate that risk. And so if we can completely eliminate that risk, that's better. And then on top of that, these other two methods tend to work much better than the manipulation. And so we're going to talk about these right now. One of them is option two, that is Maitland mobilizations. So grades 1 and 2 would be for pain reduction, grades 3 and 4 for improving range of motion. So if you did that testing and it was painful and limited, or maybe just painful, you do grades 1 and 2. If it's not painful but is restricted, you'd use grades 3 and 4. And it's always nice when the testing turns into the treatment. So right here, you just see more or less the test position. We're going to stabilize the occiput here with my left hand, right hand on the forehead to apply the mobilizations, 20 degrees of rotation to the right, and this again would be for a right OA flexion restriction. We maintain that cervical retraction, and then we just perform mobilizations. Just like that. Very simple. If the left side was restricted, we just do the same thing with the head rotated to the left. Option 3 is an MET, a muscle energy technique, or PNF, whatever you want to call it. It's more or less all the same thing. We don't really care. The patient's going to be taken to their end range that was assessed during mobility testing. Okay, same thing we did during testing, same thing during the graded mobilizations. As you might guess here, this is going to be again for a right-sided OA flexion restriction. Now, From here, the patient is instructed to look upward with their eyes. Okay, so basically her eyes are going to come up towards my hand and gently detuck their chin while the PT, should say the PT, is isometrically resisting that movement. And that's going to be held for 6 seconds. So obviously looking up at the eyes, it's just looking up. Now, when we think about detucking the chin, obviously tucking it is what we're doing. We are applying this force. To detuck the chin, they would have to do the opposite movement. So it's essentially moving into more of a protracted position. Patients don't usually understand that, so we say detuck the chin. And I educate them on this before we ever do this. So you know how to tuck your chin. Now I want you to detuck it, go the opposite direction. And the PT will resist that, okay? So I'm going to tell her to look up. You'll see that in a minute. She looks up, and then she is trying to detuck her chin while I hold against that by trying to tuck her chin. We hold that for 6 seconds, and then we relax. I tell her to relax, and then I'm able to push, like you saw right there, into a little more range. And then we just repeat this process, and we repeat this process until there's no further progress or there's no longer any restriction, okay? And again with this, like anything, you want to use that test, treat, retest model. So after I perform this PNF technique, I'm always going to go back to the test and compare it to, presumably there's an unaffected side. Now, if they're both affected, I'm going to mobilize both of them and still compare, okay? But always use that test, treat, retest model. So now at this point, you have tested for OA joint restrictions. You've identified one, most likely inflection. That's what we're going to stick with here. And you've treated in session with whichever mobilization you chose. Now you need to give an exercise or exercises to the patient to reinforce their gains at home. This is where the HEP comes to play. And there's usually 2 exercises I'll give. I'll definitely give this first one regardless of which patient it is. Cervical retractions in 20 degrees of rotation. This looks exactly like the treatments we did in session. And then the other one we'll get to in just a minute. This one is a suboccipital stretch. I'll give this to patients for the ones that may have tight suboccipital muscles that are contributing to the tendency for that joint to be stiff. Okay, but let's go over the first one first. Cervical retractions in 20 degrees of rotation. This looks just like the mobilizations. So let's suppose my right side is restricted. Which direction do I rotate and how much? Well, it's going to be to the right, 20 degrees, okay? I'm going to do about 10 repetitions per affected side, hold 6 seconds per repetition, and I'm going to rest maybe 6 seconds between reps. The exact amount of rest doesn't really matter. Just make sure the patient's able to handle that, okay? So let's take a look at it. I'm going to sit up nice and tall, rotate 20 degrees toward my affected side, in this case right. One of my hands goes behind my head. Doesn't matter which one, whatever's most comfortable. The other hand, I'm going to have a grip kind of like this and push on my chin. Okay, this is a passive cervical retraction, but again, I'm going to do this for 6 seconds. Here we go. 20 degrees rotation right. 1, 2, 3, 4, 5, 6. Relax. And they can stay in that rotated position between repetitions. Then I'll do it again. And so on and so forth. Okay. Again, that one is passive and it's always 20 degrees rotation toward the affected or toward the stiff side. And then the suboccipital stretch in 20 degrees of side bending, not rotation. This is a static stretch, and if we have tight suboccipitals that are contributing to their impairment, I'll also give this one. And I can tell if they're tight just by going back there and palpating those muscles. Since it's a static stretch, we'll be holding it longer, so 30 to 60 seconds per repetition. And because that's a longer duration, we'll use less reps, maybe 1 to 3 reps per side, okay? You can always shorten the duration of the stretch and just increase the number of repetitions if need be. But usually for static stretches, we want that 30 to 60 seconds for maximum effectiveness. Now, for this stretch, this is different than the first one. This one is 20 degrees of side bending away from the affected side. So let's say my right side is affected. That side bending is going to be toward my left. And you can test this on yourself if you kind of forget this. If we want to get a stretch of the right suboccipitals, that stretch to the left is going to get that area. So what you're going to do is you're going to start with your head in neutral, get that same stretch position, hand behind the head, one on the chin. And then if I just go like this, cervical retraction, I'm getting both sides about equally. Some people may feel that, some may not. If I want to bias those right suboccipitals, I'm going to side bend my head about 20 degrees to the left, and then I'm going to do the cervical retraction. You should feel more of a stretch on the right side. If for whatever reason I wanted to stretch the left suboccipitals, I would do the same stretch but to the right. I can feel that one much more on the left. So this is always 20 degrees of side bending in the contralateral direction. Okay? So hopefully all this made sense, gave you some good ideas for testing, treatment, and reinforcing exercises at home. Please make sure to like this video, subscribe to my channel, and hit that notification button for notifications for all videos in the future. Thank you so much.